Started. Welcome everyone to our NAMI Lunch and Learn, a regular thing every third Wednesday of the month. This month we have Rachel Fry and a team of folks who help in our community with medical withdrawal and detox treatment. And it's going to be an important, I think, set of information for us, all of us in Iowa City and the surrounding area. I hope to learn a lot more than I do have now. A brief bio for Rachel, and I hope her team will introduce themselves as well. She's been an RN for 34 years with experience in high acuity psychiatric services, child through adult, trauma center care, elder services, hospice, and executive management in healthcare, and outside of healthcare as well. And now she's back to mental health services and substance use disorder treatment. She's been with Community and Family Resources at GuideLink for 2.5 years, and she's responsible for these services we're going to learn about today. So take it away, Rachel.
Sounds good. Thank you. You bet. Thank you so much for allowing me the time to kind of let you see a different side of things with mental health. When I started my career in mental health, substance use and mental health were hand in hand, and it was all dual diagnoses. And we had multiple units of dual diagnoses, including inside the hospitals that I worked. So it was weird to come back this many years later and see that it's been so kind of segregated, when I've never thought that was actually kind of how the real world works. So came back in from the psychiatric side, honestly, with experience in medical withdrawal in the past. And they were silly enough to tell me I'm responsible for the detox, the sobering units. And then I'm responsible for the medical side of residential in Iowa City and in Des Moines. If you want to hit my first slide. So sometimes kind of understanding who we see and what we see, right? We are an open community medical withdrawal detox unit. There's only 2 of us left in the state of Iowa at this point. I think a couple more might be coming, but most have all been shut down because of a reimbursement option. You know how that is. And that's what's really changed the scope of practice in regards to substance use and mental health. Honestly, I would say I don't know that I can tell you more than 5% of the people I've ever worked with didn't have a mental health component to their substance use diagnoses. If they understood it or not, it is there. So to me, it is hand in hand. In the this last 3 quarters, so January to current, we've seen 515 individuals. Average stay is about 2 and 4. You can see where our substances are. Alcohol will always be the leading one in Iowa. It's pretty common. But I think sometimes people are surprised we see as much stimulants and opioids as we see. I think the belief is we would see 40% opioids, but the reality is the highest use is actually alcohol. Average age is mid years, more men than women, 13% without homes, majority is Caucasian in this area. And my unit alone covers 48 counties that have come to us with staff. You can just hold for a second. Have come to us for services because they cannot find services elsewhere. So we have people traveling 2, 4, 6 hours to come see us and go through the medical withdrawal process. We ask a set of questions. It's about their use, frequency, how much, how long, if they've ever had withdrawal before, if there is medical negative outcomes that they've had from withdrawal before, and they actually get screened on the phone before they ever decide to get in a car if we're going to admit them or not. I don't want somebody driving many hours to get to us for us to turn them away and turn them around, because a lot of individuals don't always have means and resources to do a lot of traveling. Most of the time, this has been the multiple times, and I tell my staff multiple times, you never know when the last drink or the last injection or the last pill is going to be. We may see them once, we may see them 100 times. But we never know. So we're not here to judge, and we're not here to expect anything but cooperation with them and us, and showing respect with us and them, and getting them through the medical side of what happens in medical detox. I tell people that opioid withdrawal is the kind of ugly one of life. It really is very painful. And most individuals going through it would rather die than be alive, because it is not very nice most of the time. The thing with it is they will not die from opioid withdrawal. Alcohol withdrawal on the other side is actually quite the opposite. There are several different medical syndromes that can occur with alcohol withdrawal. A lot of times we talk about the worst ones, but it is the one that has the most negative outcomes for individual. That includes cardiac issues, respiratory issues, strokes, other things like that, but also includes seizures and what's DTs, but we'll get there a little bit more. So what we do here is we're very fortunate. We have an 8-bed unit. I would love to have more, because there are times I have to turn people away. We have increased our census pretty significantly this last couple months as well. We're seeing that on the sobering unit as well. So I don't know if they've just finally decided we're here, or if there's some kind of trend occurring that is increasing people's stress and other problems. We all know what groceries cost. We all know what housing costs. We all know what jobs look like these days. So it could be that the situation is really just escalating with some of the other things we all feel from our lifetime. A lot of times what occurs, and I think I have this in that third one, so I'm not going to keep talking there. I appreciate everybody's time. I apologize. This is a little bit ad hoc. This is kind of just me talking about what I do and what I've done. So please feel free to ask any questions at any time. But it's not that formalized. Here's 10 slides. We're doing this a lot lighter than that. What is medical detox? Shaking, sweating, nausea, vomiting, diarrhea, anxiety, not being able to sleep, blood pressure, other issues. Like I said, opioids want to die. They're not going to. Alcohol, on the other hand, are. Seizures frequently are either two reasons. Either they are a very high alcohol user and they completely go cold turkey, and their blood alcohol drops so fast that their body's not used to it and it will seize. Or they have just had so many withdrawals and been using for so long that the body itself really gets to a point it doesn't know what else to do but seize when the chemicals start moving around. In my history, especially when I was in trauma, I knew 3 different individuals that were in their 30s to range, early young life, and literally could only sleep about 2 hours a day, carried a 6-pack around all the time, drank probably a liter or a handle of liquor plus a 24-pack a day, and was told, if you do not stop drinking, this is your last time, we'll detox you. The next time we won't be able to keep you alive. So that's why we get so serious about medical withdrawal. People talk about DTs. It's a thing that gets thrown around and everybody thinks that's the shaking process, and it is not. DTs is actually delirium tremens, and that's a true level of psychosis. We've seen 3 of them here in the last 3 weeks that we've needed to send into the hospital. And that is really when somebody becomes so confused, irrational, unable to follow direction, a lot of times just scared and wanting to run. So they are truly in a psychotic state. And frequently these are admitted for anywhere from 3 to 5 days and can actually be put into comas to try to wield off the body's reaction until we can actually bring them back and be awake. What we do is evaluate their needs. We treat symptoms based on what we call a COWS or CWA, which is a bunch of information we look at and talk to that client and say, yeah, this is withdrawals. So we base our treatment either with Librium or Ativan based on the symptoms we're seeing, and a myriad of other things for nausea, vomiting, diarrhea, and other options that we have. We are directed by what's called standing orders, meaning we do not have a doctor here writing orders. We have a group of orders that we can follow, and we call doctors when it's outside of that realm. So my nurses have to have very acute skills in evaluating clients' need. During their time with us, they'll see a nurse practitioner, which is basically to help monitor the medical stability throughout withdrawal. They get an SAE, which is actually a substance use evaluation, and that's done by one of our counselors, which is kind of like a doctor's order in substance use for any level of care that's appropriate for the individual. So it could be residential, it could be outpatient, it could be individualized, but that evaluation discusses with them those opportunities, and then we try to obviously match them up with the things that fit with them, either in our community here or in their community. Since I said 48 state counties, not everybody wants to travel back here 2 or 3 times a week for treatment. So we have to help them find other resources in other areas. One more.
Do you use anything like Suboxone or any other kind of medication assisted treatment beyond the in the recovery phase?
We actually start it. So if you're going through opioid withdrawal, the gold standard and the accepted standard of care is actually Suboxone. So we tell individuals, and some have the experience, they have to get to a point that they're actually really, really sick. A lot of body pain, nausea, vomiting, a lot of shakes, a lot of sweats, even hearing voices, hallucinations are not uncommon whatsoever. And with that, once they get to a certain number in this evaluation scale, we start Suboxone, and it's called an induction. So we'll do 2 milligrams every 2 hours. And our numbers are a little higher than the standard, but this is what we've practiced at because it's what we've seen, is we'll go up to 16 milligrams in 24 hours. After the first 24 hours, then whatever number they land on that maintains them with those symptoms and the cravings, we will do in divided doses for the next 24 hours. So if you land on 12, we'll do 6 in the morning, 6 in the afternoon to try to kind of start regulating that body on the Suboxone. And when they leave, we obviously work with them to figure out what MAT clinic they want to follow with.
Okay.
There is one, a new one that is over in Community and Family Resource Building in the outpatient side that just opened up in the last month and a half. They do Suboxone, they do naltrexone.
It's nice to know we have MAT or medication assisted treatment available.
Yeah.
I know definitely it's an important drug for people in recovery because it helps them get better in terms of, and helps them kind of clear the head for therapy, which is an important step. Yeah. Well,
and
thank you.
There's a variance view of what that is, what that means to everybody. We have to make them kind of wait till they're sick, because if we give that drug too early in the withdrawal process, we actually send them into something that's called precipitative withdrawals, meaning I don't feel good today. Now, 2 minutes later, after giving them Suboxone, they can be 110% worse.
Yeah.
So there is kind of an art per se in working with that individual to figure out what level they're at with their symptoms, what they're looking for. And opiates, cover that receptor very well. That's why they're being used. And what Suboxone is basically a synthetic opiate that covers it at about 75%. So if you think the fentanyl or any other morphine, heroin, whatever they can get a hold of, that's 100% coverage of the synapses. What Suboxone does is come in and try to replace it at about 75%. And that's kind of the average of what it feels like to them. Is it's not gone. They don't get the high. They get the coverage of that, for lack of better answers, for the withdrawals as well as that craving response. Not everybody continues it. I've had people use it through us for 3 to 4 or 5 days. So they can kind of get through that, and they want low dose and they don't want to take it with them when they leave. Others, they are going to stay on MAT treatment for an extended period or a short period of time. It can be increased, obviously. It can be withdrawn, obviously, hopefully by a step process, because it's not a drug to just stop. They'll literally send themselves back through withdrawal from Suboxone, because again, it's an opioid stimulant coverage issue. I think the one thing people have the hardest time with, either with alcohol or opioids, is once we get them to a point, typically about 24, 36 hours after they start their withdrawal, they get an exceptionally fast rush of emotions. And that is the one thing they were not expecting, right? Because why do we use, right? Why does individuals use? Because they're basically trying to squelch the feelings and the memories and the thoughts that they have. That's why they're not possibly even seeking mental health support, is because they're self-medicating with something that is causing significant damage to them. So that 24 hours after that first start of their withdrawal is what I kind of say is the gold period for them to either decide to stick this out and keep going or to run and leave ASA. And that does happen to us because they get a rush of emotion they don't know what to do with. I had a young man who played for one of the universities on the football team. He was kind of one of those star players, but he ended up having to be retired because he'd taken so many hits that he'd had so much traumatic brain injury before he was 22. He had been on meds for so long to keep those pain elements down because he was taking these kind of hits. And that got shut off when he got retired from the university football program, not here in this town, but within our country or within our state. And I got him at the age of 24 after he's been using street now for the last 2 years. And it was his first time to ever go through withdrawal. And the symptoms were rough-ish, but not as bad as many that we see. But his biggest thing was he was kind of having a panic attack because he goes, I don't think I've felt feelings since I was probably 15 years old. I don't know what to do with this. I don't know where to go with this. So that's why, again, I'm always going to be a huge proponent of dual diagnoses. But those are the individuals that either go through our CSB program here in GuideLink, or I hook up with our counselors or psychiatry that we have, or others, or wherever they're headed, because they're a high reuse risk because they don't know what to do with all those things that just haven't been part of their life because they've been hiding under the drug or alcohol. What we do is a safe place, initial setup. This is sobering, obviously. You can see those numbers. I'm going to give it over to a much more educated person that will probably not stumble over her words as badly as I have. We see about 459 clients this year. It's increasing rapidly. We currently have 4 beds. Originally, the thought was going to be 10, and it was more like mattresses on the floor. That was found not to be in the best interest of everyone, the client and or the staff. So right now we have 2 kind of big old chairs that recline, and then 2 beds. I do believe probably we will add a couple more as time goes on, but I don't know that we'll ever get to that 10 level. This does see a larger portion of individuals without a home. And they've seen actually, 39 counties have come to them as well, because there's only so much hope and almost safe places to be. I'm going to let you take kind of into your world, and please introduce yourself first, much more eloquently than I have, I'm sure.
My name's Tanya Havlet-Smith, and I work for Johnson County Ambulance. We kind of oversee the sobering unit here at GuideLink and work with Rachel and CFR up in the med detox area as far as transitioning patients from our unit to hers. We have 4 full-time staff, and then we have probably about 15 or 20 part-time staff right now that kind of pick up hours as people are taking vacation, that kind of thing. But all of our staff go through a pretty lengthy process of orientation. It's one of those things where you never know where you're going to get an intake. So some people do it or a longer orientation so they can actually see our intake process, that kind of thing. This is just a presentation that I had kind of made also for some of our newer staff. Kind of explains a little bit about what we do in sobering, kind of how it goes through the different areas, that kind of thing. So some of the objectives of this is we're going to detail kind of what substance use disorder is, highlight the pathways specific to GuideLink Center and what we do here. We're going to go through the SBIRT evaluation, and we'll kind of explain what that is. Detail alcohol withdrawal symptoms so our staff knows what to look for, and how we're going to evaluate people using that CEWA as Rachel had discussed. So alcohol is our top disorder, as Rachel had said. So we're going to go ahead and do that as our first line of training. It's the most common substance use disorder. Roughly 28.8 million adults are affected by it. And roughly 50% of those with the alcohol use disorder are going to have withdrawal symptoms. So some do, some don't. We never know kind of how that is. So this is our pathway of when people come to our building at GuideLink. they first meet with a triage counselor, and then we kind of decide where they go from there. If they're strictly looking for mental health, they can go right into our mental health CSB area. If they are strictly looking for med detox and they're already having symptoms, withdrawal symptoms, they can usually go right into our med detox. If their alcohol level is too high and they're not maybe having symptoms yet, we'll start the patient in sobering and kind of go from there as far as what their path is going to be. So within our sobering unit, we have usually a tech that works for community family resources, as well as an EMT or paramedic that oversees the area. So we'll monitor vital signs when they come in, of course, and then throughout their stay, depending on what their alcohol level is, what kind of symptoms they're having. We'll do that every 2 to 4 hours. We provide comfort measures. So we mainly give them a safe place to relax, rest. A lot of these people have not eaten in days. So we'll give them some snacks, a sack lunch if we have them available, if they're going to be here for a decent amount of time, and hydration. So main thing is we're getting Gatorade or water into these people because most everyone that comes here for substance use has some sort of hydration issues with them. If they're here strictly for sobering, we will perform an espert. And then we can also offer other resources within our area. So an espert is a identification test for our clients. We have a worksheet that they fill out. They'll answer questions. We score that, and then we use that score to educate them on what risk level they're at for unhealthy drinking and amounts of alcohol. So this is what the espert looks like that the patient will complete. And this is, really important when we have some of our younger people that come here. Our sobering unit is open to anyone that has used any substance. So we will get a lot of times, as Rachel said, some unhoused individuals, but we also see a lot of students within our area that maybe have just had too much to drink, lost track of their friends downtown, whatever the case may be. They're not in trouble. They haven't done anything wrong. They don't need to go to jail. They don't need to clog up our ERs and have, a nurse sitting by them. So they will come here. This is a great tool that we can kind of help educate and evaluate them. So they will answer our questions here on how often they're drinking, kind of as Rachel said, and then we will give them a score. And then as that score goes through, it will give them an idea of what kind of treatment maybe we need to go from here. So there is a little diagram here. It's kind of hard to read. It's a little blurry, but talks about what effects that drinking is going to have on their body and what risk level they're at to become more of an addict. So we want to make sure that we're trying to catch those people at an early stage and evaluate what their usage is and try to get them to the right programs. This just talks about like what a standard drink size is. A lot of the younger generation especially don't understand when they go out, they're getting more than one shot. They're getting, mixed drinks that have multiple different alcohols within them. So this gives them a general idea of what a drink size is, and then also for our staff, what standard bottle sizes are. So when people come in and they say, I drink 750 milliliters, like we have to kind of look and say, oh, okay, that's what we call a fifth. That gives an idea of how many ounces and stuff that we can report to our detox team of what we think they might withdraw a little bit more if they're drinking more towards the handle side of things. We can then transfer people into our med detox area if they meet some qualifications. So if they are having symptoms, we'll monitor their vital signs, watch for signs and symptoms of withdrawal, and keep a close eye and communication with our med detox nurse. Alcohol withdrawal is just a range of symptoms that can occur when either you stop using alcohol or you significantly reduce that amount. So as Rachel said, someone that maybe was drinking a 6-pack and a handle of alcohol a day, and maybe now they're like, hey, I gave up the hard alcohol, now I'm strictly down to 6 beers. They can have a significant withdrawal just because they've dropped using what they were doing before. So can range from very mild to severe in symptoms. Oh, well, that was weird. That just kind of disappeared. There we go. So symptoms can be, as Rachel mentioned, anything from headache, anxiety, uh, excessive sweating, tremors, nausea, vomiting. Everything kind of goes into overdrive within their body. So these are all of the symptoms that our staff is looking for. So sounds familiar. We've seen those symptoms. We ask every patient as they come in. This box down here at the bottom is on our intake form. So as people come in, we kind of ask them, have they withdrawn before? They say yes. We mark kind of what their specific symptoms are because every person is different. It gives our staff a good way to know what they're looking for with each of those clients. There's no specific time as far as how long they're going to be in sobering or how long it takes them to sober up. Just kind of depends on the client, what their system is like, how well hydrated they are, how healthy they are outside of that. We mainly tell people that 6 to 24 hours is when they're going to have those symptoms, if they're going to have them. And that's when we're kind of talking with our detox team and making sure we're getting the people moved up as they're needed to. So there's no order of events. We treat the client's symptoms as they arise. We continue to monitor them closely. Maybe instead of every 4 hours, we're doing vitals every 1 to 2 hours. And again, communicating with our detox team. We also do a CWA scale, and these are the items that we look for. Again, all the normal symptoms. They have a scoring system between 1 to 7 for most of those. And we just go mostly by what the patient is telling us as far as if they have a headache, how severe is the headache, that kind of thing, and that scores them. That helps detox know when it's time to go up to the detox unit. Again, as Rachel said, thinking outside the box, it's not just what they're telling us as far as symptoms. We also look for increased blood pressure, heart rate, body temperature starts to rise. And then also one of the other places that we can go if we come from sobering, we can go right into crisis stabilization. They just have to be under the legal limit and they have to be able to stay awake and talk with their CSB team and make sure that they're able to tell them what their story is, why they're in crisis, and see that we can get things met for there. That's all I have. This is my contact information and a QR code that goes straight to GuideLink's webpage. Again, our services here in sobering, we take any sort of substance. I know there's some other sobering centers that only do alcohol, but we do any of the ones that Rachel had listed before. So I feel like we do a great job of trying to do that diversion from the ER or from jail. And yeah, that's where most of our clients are either walk-in or from law enforcement.
I would guess law enforcement loves having you as a partner.
Well, we try, and I will say our last data stuff that we had pulled, I think the normal intake time for the police to drop somebody off is less than 5 minutes. So in fact, I just had one the other day, 2 minutes. They fill out a small sheet, just who they are, who the patient is, how they came in contact, and where they would have taken them had they not come here. So I think our police forces are liking the fact that they're not writing such long reports and having to wait at the hospital to get them seen or process everybody through jail when they haven't done anything wrong.
Right, right.
So
what kind of substances are you seeing the most here in our region?
I definitely would say alcohol is the first one, but we've had a pretty high uptick of meth in our area. And that meth is always usually mixed with a plethora of other things as far as fentanyl, MDMA. Those are kind of the two most common. But I would say that's definitely our second highest substance that we get in here. So,
yeah. What we do see though is if we do get opiates, it is someone using substantial amounts.
mm-hmm.
So, they call them Perk 30s. They're little blue tabs. They look like Percocet. They absolutely are not. They're fentanyl. They don't even know they're taking fentanyl sometimes. But we're talking doing 10, 20, 30 tabs a day. And it's either by, snorting it, smoking it. There's also a way of calling boofing it, which is beyond my thoughts, but that is actually making it in a liquid and actually injecting it in the rectum because it gets into the bloodstream so quickly. IV is definitely on the table as well. So they get very creative in what occurs when we get into the meth and the opioid side. You can do meth the same way. We also see kratom, not a tremendous amount, but if we see kratom, somebody is doing like 100 pills a day.
Yeah.
That is something you can buy at your local convenience store, literally 2 blocks away from us. You can see the sign that says we sell kratom. Kratom is actually a synthetic opioid, and it keeps changing its amounts or drug additives or whatever so that the DEA can't actually catch them. And it is as addictive as opiates are. People don't think that because they can buy it at a convenience store. That can be IV, smoked, boofed, you name it. If it can be done, it'll be done. And that's the one people kind of forget. We can actually get our hands on things in convenience stores that are very, very detrimental. Recently, literally within the last 2-3 weeks, I had an individual come in that we couldn't figure out what the symptoms were, sent her into the emergency room. I called my contacts in there and said, what are you seeing and what's going on? And we've seen a really interesting uptick very quickly of something either called bath salts, or they call it a zombie drug. And that's what this individual looks like. They look like a zombie walking. There's no recognition, not able to talk to you, not know what's going on. And the university said they've seen several in the last couple weeks.
Yeah, they look like a contortionist at times. Their arms, their legs, they move in different ways that you would almost see a contortionist if they were going to try and fit into a small box or something. It's very unique the way it presents.
So, we're getting to colder times, so that always makes us a little more anxious. And what we do is because more people, even if you're unhoused or other, start congregating in smaller sections and things start getting passed around. So it's interesting. Our job is never dull. The thing I tell my staff, and I don't even have to tell the EMS staff, they know this better than anyone, is show respect, shake their hand, make eye contact, and say hello. And you'll have a respectful outcome, even if they're not doing well. And some people don't do well coming down. It is a rough process at times. But I've had people say I've never been shown respect in so long. I don't know how to make eye contact anymore. That's why I said dual diagnosis is my favorite way of talking about things, because they're self-medicating and it turns into these 2nd-degree diagnoses. And you guys know the stigma that goes along with all things like this. But when I was up at the State House trying to talk with some individuals, the individual talking to me said, this individual, this senator still believes it's a choice, that substance use is a choice. And it is not. It is a disease. I liken it to diabetes or renal disease or anything else. You get a long-term chronic disease, you have to choose how you're going to take care of yourself to what your life is going to be an outcome of. I could eat a chocolate cake every day if I was diabetic, but the outcomes are going to be negative. If you have substance use disorder, you can choose to drink every day and it's going to have negative outcomes, or you work yourself through a very difficult process called recovery. And it can be a daily battle with what occurs even for years thereafter. But it's no different than a chronic disease. It's just how you choose to manage to it.
Right. Yeah, just like mental health, there's just so much stigma involved. Yeah.
Yeah, I think our staff.
This is very interesting. Go ahead, tell us.
So I was going to say, I think our staff does a great job in sobering as far as once the client has maybe had some rest, got some nutrition in them, got some hydration, they kind of wake up and they, then they want to talk about their issues. We do a great job of including our triage team to come back and chat with them, do some crisis counseling if that's all they want. They'll also do like I said, an intake into our crisis stabilization unit. But I think all of our staff is very well versed in knowing kind of when's the right time to make that switch, and when to offer them more resources. So even if someone doesn't want to do an admit to our crisis stabilization, we at least give them resources that they leave with, whether it be setting them up with a primary care physician, whether it be, figuring out med management, kind of whatever they need. We try and do the best we can to get them resources or to crisis counsel them at least in the minimum before they leave.
Excellent. This has been a wonderfully educating process here. I didn't know this was available.
Yep.
We hear that a lot. We do hear that a lot. We are very fortunate. We are in GuideLink, the Access Center. Currently, it's the only detox unit in an access center in Iowa. I think that will be changing in the near future. There is one other sobering unit that is in Lynn County, access center there. But a lot of those centers are focused more on mental health, which we understand. But a lot of your clients and those that you work with through NAMI and others have mental health disorders that still have a substance use disorder on top of that.
Right.
Which is the chicken and which is the egg? I don't always know.
Yeah.
We take care of psychoses in a community-based. We have no monitors. We don't do IVs. There is no call lights. This is community-based. They have to be interactive with us. So we have to know that person can get out of bed and tell us, hey, I'm not feeling well. Can you come look at me? If we're getting busy and we haven't gotten there in a time, because it can change very quickly from I'm doing all right to I really feel like crap now and something's changing. So we've had the unique opportunity to treat many people and hopefully someday think in our minds that we've had some big impact. But substance use, not completely unlike mental health, we have a small margin. So we have to do a lot of self-talk sometimes to keep seeing similar faces and hope someday that their choice will change a corner or make a life change for them.
Do you think that the state's reorganization into mental health regions will help build more of these important units?
I'm not, I've been around the block several times. I've been, like I said, my background is very interesting, but I'm sad to say, our current governor, her past predecessor, and his 2 units there. That's when I was in the most time as a youth in substance use and mental health, especially mental health care. And every time a new policy came up, it meant less money, not more. So am I optimistic? I think it'll be interesting to watch because they put everything under a big umbrella. That includes HACAP, elder services, all of the different elderly waivers, mental health waivers, all those kind of BDs, DDs, all of those waivers are underneath this umbrella as well. So they've stuffed it very, very full with very many different directions, not just substance use and this, but they're saying this is the reorganization for these 2. They're increasing the cost for the administration of it through ASOs.
Yeah.
Okay, so that money comes out of that pocket no matter what. But I've never seen that pocket not get a little lighter and a little lighter based on these situations when they've made these adjustments in the past. So not being pessimistic as much as factual basis, past behaviors predict future outcomes. I'm not sitting here holding my breath. I'll be honest.
Just wanted to add, I just had the great opportunity to tour GuideLink with Taraji, and it is an absolutely beautiful center. And I really love the triage focus. I have family treatment court history, and safety and permanency, along with a lot of mental health in my background. So I absolutely understand the beauty and necessity of what you all are talking about and doing. So thank you very much for everything that you guys are doing and for that. So very wonderful discussion, ladies. Very wonderful. Thank you.
Thank you.
And can you think of anything you'd like to add? I know you've got lots to say. You know, but,
Anytime you'd like something more formalized or more professional.
no,
We do
good.
have an entire team that does prevention as well. They have some great pieces of information and other things that is, I think, valuable for people. So we also know lots of people and resources. If you want more in any other direction, we're happy to help set that up for you as well.
Right. One connection I thought I'd make is with our new mental health first aid instructor at NAMI. And if she could come tour, but also see certainly what kind of services you offer and get a little bit more, I'll send her this presentation because it will really add to the substance use portion of that class. It's really
Absolutely.
helpful to dispel myths. You know, people do have that, you know, they treat substance use like mental health as if it's a choice.
Yeah, and it's not.
No.
People have a very strong perception of what we do. You know, if you my numbers slide again, I'm kind of data driven. Less than 13% of the clients I take care of are unhoused. There's probably only about 25% of my individuals are without a job.
Right.
So we have real individuals, no different than people you work with every day or see every day, and they can have professional jobs or just everyday, you know, need and support jobs. And stress is a big factor in life. And with stress, then we can't handle that. Again, from the mental health, right? Coping skills, decision making, overwhelmed, these issues. So what do we want to do is not have that feeling anymore. So we make ourselves numb.
Right.
And then you get used to the numb, and the numb becomes something much deeper and much more insidious. And it's it is probably even more hidden, honestly, than mental health, believe it or not, because I don't want anyone to judge me, right? We all know that from mental health, but substance use is a hidden little secret in the corner that I stash things and I hide things and I lie to people and I manipulate, and I have to use skills to make that person codependent on me. I need to use my manipulation skills so that everybody believes me and doesn't believe anybody else. So it grows a set of skills that are vastly different than those that just face mental health. I'll be honest, because I will tell my staff, every person lies to you, get over it. They're addicts. Okay, they've grown skills to be an addict and they don't know how to put them down now. They haven't figured out what to stop that behavior that got them to this point and or has covered up for this point. You know, frequently we get a phone call and somebody goes, how much do you drink? Oh, I only drink 6 beers a day. Okay, well, you really don't need me, to be honest. Do you need to go get a substance use evaluation and probably talk to a counselor? Because obviously you think you have a problem or you wouldn't be calling me. But then we start asking questions. Well, that 6-pack is actually tall boys, which are equal to 3 beers. And they drink IPAs. So that's 8 to 10% versus a 3 to 4%. So all of a sudden we go from 6 beers to a case and a half. Oh, by the way, I only drink 3 other drinks, but it's shots. So I have people drinking 10, 20 shots a day throughout their day on top of the beers. But they forgot to tell me that, right? So, we're not here to judge, but they lie. They have to lie to themselves. And until they're ready to stop lying to themselves about really what's going on here, they can't stop lying to me or my staff or sobering or anyone else in the care continuum because they are too scared to show the mask coming off of what that looks like. And I love it. I laugh because I have a very bad sense of humor, I guess, for the years of trauma and everything else I've worked. She understands. We have very bad senses of humor in medical care when we've done certain jobs, but I find it absolutely fascinating when an alcoholic tells me that they can look down on somebody who uses meth or opioids or other drugs because, you know, I just drink. I'm not like them. Addiction is addiction is addiction.
Right.
Doesn't matter if it's gambling, alcohol, or drugs. But because alcohol is legal, moral, and ethical, because we can sell it as soon as you're legal to have it, and it's not an illegal substance, they're not buying it on the corner, then there's kind of this rise of holier feelings that I'm just an alcoholic. See, they're drug addicts. So it's very fascinating. I see that a lot. And it's really a stereotype we have to break down for them to accept the word addiction. Because being an alcoholic's not that big a deal. Being an addict is.
Right. Right.
So a lot of terminology is very fascinating to watch them evolve through and try to embrace as they get past my need and we get them ready for the next step, outpatient or other. We always pray something other, but we get people that come in that are bartenders that tell me, oh, I just need to get it back under control. Okay, well, I'll see you back in about 3 to 6 months, maybe less, but you know, we'll meet again.
Yeah.
It's not something you can get under control, you know. Like I said, I've worked mental health, and I think the one thing that was easier in one respect is I could give a medication that could solve a problem for many people with mental health issues. I can't give a medication to solve substance use.
Right.
And that is the kind of the bifurcation at that point of the different kind of concepts that we can use in taking care of somebody with a dual diagnosis.
Well, you definitely have a challenge. And thank you for trying to meet it, because I know it's growing definitely every day.
It is.
Yeah.
Thanks for joining us, all of you. And
It was an honor to be asked. So thank you
Yes.
so much for allowing us the time with you.
well, I really do appreciate it. I know it was very last minute. We had someone step out from another presentation, and this was wonderful. Thank you. We'll have more certainly from, I've been talking to Abby, and you guys have a lot of services you can talk about.
Sounds good.
All right.
Have a great day, everyone.
Thank you.
Thank you.